questions, feel free to ask them in the chat. I'll try to keep an eye. For those who don't know me, my name's Dave. I'm a paediatric PEM consultant from the northeast of England. I've been doing POCUS for quite a while now, and this is one of my favourite topics, POCUS for appendicitis, one of my truly favourite questions to answer using ultrasound. So this is what I'm going to be going through today. Why should we be doing it? How do we do it? And if we do it, how reliable is it? So another disclaimer, okay, fairly obvious. I'm not, nor have ever been a radiologist. However, I have been trained by lots of different radiologists in scanning for appendicitis. So anatomy for dummies really to start, and I just like this diagram for a few, this picture for a few reasons. One, it obviously shows the typical position of the appendix, but I also like the way it demonstrates the interface between lots of different bowel loops, and that's going to be really important as we continue. If you remember nothing from today's talk and you're not a surgeon who sees this every day, remember this diagram. I always talk to people about this diagram and I put my hand up like that. And some people, some trainees nod and understand what I mean from the anatomy diagrams. Others can't remember the picture I'm talking about, but this just shows the variability in the appendix position, all right? That's going to be of relevance to us when we're scanning. In particular, look at what it's demonstrating between the pre-ileal and post-ileal. So obviously in relation to terminal ileum. So why bother? Well, a normal talk would go through all of these kinds of things, wouldn't it? It would say that POCUS is quick, it's safe, it's easily repeatable, it's portable to the patient's bedside, it's well tolerated. That's on a recent course of ours, and that's my friend's little one enjoying himself so much that he's fallen asleep, completely conks out during the scanning process. So easily tolerated by all ages. It's inexpensive after the initial outlay of the machine, but this is an interesting point that I just kind of added in, is that, you know, you're not reliant upon someone external to your own team. So if this is Saturday morning or late at night, which is when a lot of abdominal pain winds up in the department, we can make decisions by ourselves, which I think is a benefit. Okay, I'm still haven't convinced you, so I'll continue. So really, why do we do it? Well, that's because we live in the wonderful world, some of us anyway, of pediatrics, whereby headaches sometimes don't have a head cause, and tummy problems don't often have a tummy or abdominal cause. And sometimes the pain can be everywhere. It can be from a joint above involved on the limb. It can be from a completely different site or organ of the body. It's because we can have a child like this in the middle. Can everyone see my pointer before I switch to the laser? Is my mouse showing? Yeah. Perfect. Because we can have a child much like this who can, you know, sometimes be disproportionately upset for a minor injury, or we can have this wonderful child who comes in with a banana arm and you only really realize how bad it is when you fully take their arm out of their sleeve or, you know, remove a sling that's there, because they're tolerating it so well. So they're really difficult little people to assess. And I always like this paper from when I was training in my last few years as a registrar, which talked about using the things in pediatrics to our advantage, extrapolating findings, inferring different findings, you know, working around children and getting the best out of an examination. Well, POCUS is exactly like this, okay? So if I still haven't convinced you, this is a recommendation from the National Pediatric Abdominal Pain Pathway, referring largely to appendicitis, the GIRFT pathway, as some of you may be familiar with it. Now, the word ultrasound is mentioned 18 times in this document, all right? And imaging, I think, is mentioned over 100 times. So we know that these are all the statements from the GIRFT report, that ultrasound is ultimately cheaper and safer than MRI and cross-sectional imaging, that in experienced hands, it provides similar levels of diagnostic accuracy, and then crucially, that it can be shown to increase efficacy in diagnosis in terms of, just go back to the chat if people are asking, to, there's the paper, thank you for sharing, that it will go back, that it will then go on to reduce the number of negative appendicectomies that occur. So that can be well over 10% in most regions in the country and nationally on average, but it's more than double that in certain parts of the country. So children going to theatre unnecessarily, which we all would like to avoid. If you still need any convincing, well, obviously headlines like this can hit the national press on a daily basis, and I'm sure none of us would like to be in this particular scenario. So how do I do it? Well, you know, this AI image of a Geordie doctor scanning a child is going to explain all of that to you. However, as we will see, it's got most of the things right, but AI hasn't quite cracked everything. So I don't know whether I'm going to be talking to an endocrinologist there or having a safeguarding chat, but something's definitely right with that little child who I'm scanning. And I'm also clearly nowhere near as handsome as this cartoon guy. So how do I do it? How do I scan for appendicitis? So I'll always start with a curvilinear probe, all right? And the view I'm doing is very similar to that of a focused assessment in trauma, whereby we typically look in the places where free fluid might collect, all right? And we know that more likely than not, it's likely to accumulate within the right upper quadrant or pelvis. And you may see some positive examples of free fluid as shown here in all of the different positions. We obviously omit the extended fast element of the lung and subcostal windows, but these would be the ones that I do. And sometimes you will find something that alerts you to other findings. And I like to do what I call a scouting view, which is where using the curvilinear probe as shown there, I will scan at about the mid-abdomen. We're not quite down in the pelvis at this point. We can see the vertebral shadows deep to the screen. We can see probably common iliacs either side. We would have aorta if we were more proximal. And then I'm coming down, not quite, as I say, at the level of the bladder, which if I'm fanning inferiorly is going to be a bit lower, but I'm looking here in the right lower quadrant. So here's the probe marker on the screen. This obviously corresponds to the probe marker on the probe itself. So we're talking about right and left. And I like to look in this area. I've had some unbelievable surprises in children who look really, really well. A 2-year-old who we recently transferred to the tertiary centre to be operated on was one of the wellest patients that I've probably ever scanned and had the worst perforation that I've ever seen. So this classical example of that crescendo pain, initial symptoms, and then possibly a bit of quiescence of that. So in her right lower quadrant on that scouting view, I was able to see absolutely grossly abnormal appearances. To use a kind of crude expression, it had looked as though a bomb had gone off down there. So we know from our anatomy roughly where our appendix is going to sit. So it's going to lie at the base of the cecum, all right? So we can see the ascending colon and cecum, and we obviously know where McBurney's point typically sits. So in sonographic terms, we're going to place the probe roughly in this region. But there's 3 ways that I do this and 3 ways that is commonly taught. But each technique is clearly not mutually exclusive. Sometimes, using the first example there, which is a point of maximal tenderness, if it's a small child, I take the finger and I ask them to use the magic finger to show me where it hurts. Sometimes children of about, 3 and up can do that. And it's great. They might just tell you where it is sore, you put the probe on, and you get a brilliant finding. Just like Bethany, who's going to be helping me with the end of this talk, she had done a case recently, and it is illuminating when you can put a probe on and see exactly what you think you're going to find. The middle diagram relates to probably what I do most often as a starting point, which is to start quite low down on the child's abdomen, which we'll go through and look for these iliac vessels, all right? This could be the common iliac, depending on how high the appendix sits, or it could be the external iliac. It's probably more commonly the external. And then there's a colleague of mine in America who would do some work called Adam Sivitz, who did a paper that really talks about looking around and using almost a sort of lawnmower technique, basically to kind of find various landmarks until you hit what you expect. So it's about having a dynamic scan, and I think I would do a combination of all of these, particularly the latter 2, if we didn't have an obvious finding from the first one, if that all makes sense. So when we're talking about the iliacs, we're obviously scanning down. So we've got near field is obviously anterior to posterior. If the probe is in transverse, we're going to be cutting through and we're going to be seeing our vessels also in a transverse section. So seeing them as a circle, which I always like to talk trainees through as, cutting through like a CT scan, seeing a circle. If we then rotate into longitudinal, we've got the probe marker there. So we rotate our probe that way, and we have the top of the probe to the patient's head is always the convention. We're going to see our vessels in a tubular manner like this, running downwards. And in all cases, the appendix is thought to sit within this region, as per this previous diagram. We're going to go through that in a bit more detail sonographically. So one way to understand about where the appendix may be is to try to come down through to the cecum, all right? Now, within the cecum, we get a very characteristic pattern of large bowel gas. It looks like bright, fluffy clouds, and is just a real hallmark that you probably hit kind of large bowel. Within this, you might have the region between the ileum and the cecum, so the ileocecal valve, which you can sometimes identify the transition point really, really well. But typically in this region, you're going to be looking for the appendix branching off and coming off. Now, this all might sound a little bit complex, but I think what we've got to remember is that when we're seeing a child with pain in this region, if we're fairly convinced about an appendicitis, I can use data that we've recently accumulated to back this up, is that generally you'll find what you expect to find, okay? If it's a child where you're less convinced, you're looking around for maybe 5 to 10 minutes, it doesn't take that long, but you can spend lots of time talking to the child, having a really good look, graded compression, graded, extra bits of pressure, and you may be searching for something that you probably know isn't going to be appendicitis. When it's fairly obvious and you think, right, I'm going to find something here, in my experience, it really genuinely almost is every time, okay? So whilst it sounds a bit complex, it's not too complicated. This is just a diagram with the cartoon above to show you what I was talking about, the interface between different parts of bowel, all right? So bowel, so we've got musculature above, either iliopsoas muscle in this plane, and then we've got different patterns from the bowel, okay? So I always think of typically a small bowel loop is going to be compressed and small, looking a bit like this. We'll see kind of active peristalsis within it doing that, but you don't see it's typically not distended or fluid filled. If it is, those are features possibly consistent with obstruction, depending on what you see. And anyone who wants to go and find our video, we've got the video on YouTube of PEM POCUS UK outlining what features of bowel obstruction look like. Whereas, I'll just keep playing the loops, whereas in the large bowel, there's a bit of an interface here. I don't know if you can just see this dirty gas pattern. Now, at the end of this clip, this stops. So there's almost an overlap between a loop of bowel and probably a loop of bowel next to it, which I think can't be always 100%, is probably the difference between sort of large bowel gas pattern restricted within a loop and then a compressed small bowel loop. And these are some of the landmarks that you can look for. But on with the appendix. So again, if we're looking from the near field to the far, and we've got our probe marker to the patient's right, so lateral to medial, we obviously know that we've got our vessels, we've got kind of typically artery and we're told artery and vein. Same thing when we get down to the femorals, artery and vein, isn't it? When we're doing a femoral nerve block. In real life, particularly in pediatrics, they definitely tend to sit one on top of another. So in this case, the vein will be down here. And then we've got a bit of dirty gas pattern from the cecum might just arise between the muscle layers. But what we're looking for is this tubular structure projecting out. So a kind of a blind ending tubular structure. It won't have any peristalsis. And you've got to kind of interrogate every single little loop that you see. So let's have a look at some examples. So a couple of questions, first of all, as we're working through our technique. So how often, before we get into the sonoanatomy, so how often should I find a normal appendix? So I started reading this paper last week, and it said the mean for 3 reviewers across one hospital visualization was 80%. I couldn't believe this, all right? Then I realized the paper was about CT. So that's CT scan, that's interpretation of radiologists for a CT scan. That in itself tells you as much as you need to know about, other modalities of scanning, i.e. using ultrasound, if only 4/5 of the time we can identify it on CT scan. So that, of course, isn't anything to do with ultrasound because we know nobody's going to be finding normal appendixes or appendixes that often. Okay, so this is what I've found. I think there was a recent study I looked at across 2 sites that was between 10 and 20. I agree. Anecdotally, every radiologist has always told me between 10 and 20. And we're looking at data where we've got 149 patients at the moment, and we've found it on 18% of occasions. That's the normal appendix. So that's pretty good. For anyone who's on our recent ultrasound course, my son was one of the models, and someone had asked me if we could just go through technique, and I said I would, but don't expect anything, and we certainly wouldn't find, first time round his appendix. And lo and behold, it was there straight away. It was really one of the best examples of a normal appendix. So I don't know if anyone was on the course when we talked through that, but that was a good example, but very lucky. If you don't see the appendix when you're scanning, there are different things that you can do. So I've heard a few different things from radiologists. One is turning over into this left posterior oblique position, which there was a paper showed that the baseline appearances in this particular study were around about 31%. But then they improved significantly to close to 50% when they did this rolling pattern. So you're really scanning for a retrocecal appendix, potentially looking in this position, and then rolling them back onto the side and having another look. I try this a lot if I can't find it. And it's always nice to be able to obviously, make a full rule out diagnosis by finding a normal appendix. I've tried it a lot and actually it hasn't really helped me particularly. But what I'd say again is, at a research level, of course, it's important to have gold standards for, rule in and rule out and certainty. But again, in our pediatric emergency department, that's not as much what we're interested in. We're taking a condition with a known general prevalence. Not every abdominal pain is appendicitis, of course. That would be a very busy department if it was. And then we're looking at the kind of pretest probability based on their clinical presentation and their findings. We're looking at pediatric appendicitis scoring, and then we're scanning them if we've got the expertise, and we are making the decision about that. So in other words, I'm not that worried if I don't find a normal appendix. If I've spent 5 minutes talking to a child, getting to know them, understanding how, are they hungry, how the pain is doing now. And if I'm scanning for 5 or 6 minutes, or even 3 or 4, and I'm not finding what I expect to find, I would be fairly confident saying that's not appendicitis. And what we've started doing more commonly, myself and my other colleague, is we're calculating a pediatric appendicitis score, but we're actually not getting to the point of doing the bloods. I appreciate that's not a validated measure for a PAS score, but we're saying, okay, so the pre-PAS score, would be 3 points so far out of 8. We normally need a white count and a neutrophils, but actually we're not bleeding them because I'm sending all of these kids home. And so far, in terms of any false negatives, there haven't been any. So I do think it really works in this sense. So whilst you can use these methods, I don't think they're completely essential. Another technique you can do, which I was taught by a radiologist, is to go into like a reverse Trendelenburg position, and the appendix might kind of flop back into position with the patient head down. And another method I've heard of is if the bladder's not full, fill it, but if it is full, empty it. And these just might make some changes in terms of what's visible. Does that all make sense with everybody? And have there been any questions so far? No, good. Stunned silence. Feel free to jump in if there are. Okay, so the normal appendix. So we're coming through the kind of abdominal wall from the subcutaneous fat and some fascia down to musculature, and we're looking for our vessels, aren't we? So if we're struggling to see them, we can put color flow on this region. You've obviously got an adjacent muscle here, probably iliopsoas in this case, and we're looking for a loop. We're looking for a blind ending loop of bowel that does have some features consistent with obviously bowel tissue. It has gut signature, which we're going to come on to in a second, but it doesn't peristalse. All right, so you might see movement from breathing, but if we have this loop here and we have an adjacent loop over here, which we did in the previous example, you'll see classical peristalsis happening like that, and then you'll see a little loop next to it and nothing's happening. So we're waiting and waiting and waiting for maybe 20 seconds, 30 seconds, and nothing happens in the appendix. All right. So a bit more about orientation, then we'll talk through really what the appendix does and doesn't look like. So again, we see the musculature. We've got calipers on where I think is probably a good place to measure for an appendix here. And we can see we've got the musculature, got the artery, vein is below it here, and then we've got the appendix. If we rotate into long section, this might, if it looks like a tube, a line in transverse, when we rotate into long, it's going to look at like a circular end on like a tube, and vice versa. Does that make sense with everybody in terms of that orientation? It's just something worth getting your head around, similar to blood vessels, I guess. Okay, shape. So yeah, really interesting this. So I think most of the time I would say the appendix is, and there are some surgeons in the group, so I'm not gonna embarrass myself. But yeah, on scanning particularly, most of the time the appendix, when it's normal, it will look fairly curved and curled. It will look serpiginous, sometimes as much as this with 1, 2, 3, 4 loops where we see a kind of a root tip, root middle tip, something like that. I've seen before 3 or 4 times. And probably when it gets inflamed and problematic, it blows up into a straight shape like this and becomes thick and turbid, non-compressible, obviously. And I guess this funny guy, inflatable guy, that fits with my brain about what would happen to the appendix. In terms of length, I've included this to think about, well, what would be potentially too long for a loop of bowel for us worth considering whether or not it is. That's what we're seeing. You know, if we saw something completely massive, could it still be the appendix? And this was a study looking at these different age groups and the mean lengths. All right. So certainly in some studies, not anything above 7 centimeters, 7 to 8. But then again, occasionally you'll see these massive specimens where we're well above kind of 15 centimeters in length. So when we start scanning in the right lower quadrant, you're going to put your probe on and we're going to look for our vessels and we're going to look to see, do things look normal? That's our first starting point. Can we see any evidence of free fluid? All right. Free fluid isn't necessarily the most important, but it's something people are most familiar with. So I thought I'd start with that one. And this was an example that we're going to talk about in more detail with little pockets of free fluid throughout. All right. We're also going to be looking for features of echogenic fat, so bright fat, bright mesentery in this area. And you'll see from all of our examples of appendicitis that that is an extremely important secondary sign that we have pretty much all of the time when there's appendicitis. So put your probe in the right lower quadrant. You've got a bit of a feel based on how tender the child is and what else is going on, how worried you need to be. Does that make sense? Okay, so when we're talking about appendicitis, we've talked a bit about what a normal appendix looks like, and we're going to go through loads of examples of this. So don't worry, you've got maybe 10 cases, 20, loads and loads of images. We're talking about a blind ending tubular structure where from outer wall to outer wall, it should be less than 6 millimeters. That's the cutoff that's in the literature. Again, we'll talk a little bit more about that in detail. And again, when we're talking from measuring into the lumen, which is this, I guess, with the bright white stripe in the middle where there's either a bit of gas, in this case, probably gas because it's normal, right out to the edge, less than 3 millimeters. And that makes sense, doesn't it? Because if it's over 6 millimeters, what we're thinking about is this true inflammatory problem where the walls have become thickened, or could it just be a distended lumen with either potentially gas or potentially a fecalith but not have appendicitis or some feces or something else where it's actually truly all inflamed rather than just being very wide but with a very thin wall. Does that make sense? We've said it should be non-compressible. So, you know, appendicitis will be non-compressible. A normal appendix will compress a little bit with a bit of pressure. It'll go from a very circular structure to like a flattened kind of oval. In appendicitis, we always see this bright echogenic fat around it, all right? So the gain for this machine probably, you know, it looks kind of normal, could be adjusted, I guess, but even with that, we can see everything around it is extremely echogenic, as opposed to this, the only thing that's bright is really the fascial lines, which is kind of, you know, what we normally see. Everything else looks fairly nondescript. And then we can look at color flow Doppler enhancement, so for vascularization and kind of increased blood flow. And we said it's normally in a fixed position. So when we're talking about measuring it outer wall to outer wall, we talk about going from the outer dark to outer dark, which you can see typified here. And these are the layers. If we look at histology sections, this is kind of how it tends to look. The outer walls, the kind of whiter bits, are tricky because they're kind of composite edges and it's very hard to be exactly certain. So convention is to go to the outer part of the dark as much as you can, okay? Just bear that in mind for when you're looking, obviously, at an appendix. What I would say about the cutoffs and about 6 millimeters and other things like that would be that if you're really quibbling over 1 or 2 millimeters, so 6, 6.1, 6.2, or, you know, 5.9, and you're having to convince yourself that hard, I don't think, in my experience, I'm too worried about those cases. As I say, this tends to be fairly binary when you've got your patient in front of you. You're either nowhere near 6, so you're 4, you know, 0.2 of a centimeter, 0.3, 4, 5, or you're way above, you know, you're 0.7, 0.8, 0.9, 1 centimeter, 1.1, 1.2, something like that, in my experience. Okay, so here we've got some examples of different things. We've got some images that I took, and we've got outer wall to outer wall. We're measured pretty big, even if I'm not bang on with my calipers. We're certainly 0.9. We've almost certainly got an appendicolith here, so bright echogenic structure inside the lumen. We've got some brilliant clean shadowing behind the appendicolith coming down, so the ultrasound beams tend not to be able to penetrate through and pass through. They create a lovely shadow there, which makes sense. And everything else about this just looks very unusual. Fixed, very, very broad, very echogenic fat around it. So that is appendicitis. Here we've got some loops showing you different things, and you can probably appreciate all of these features in this view, okay? If you see this big circular structure with thick walls surrounded by echogenic fat, that is appendicitis. Okay, and you don't need to worry anymore. You just need to do whatever you would normally do with your surgical team, and hopefully they believe what you're telling them, because these are grossly abnormal appearances, all of these. Right, talking about secondary signs, I would say secondary signs are the most important thing, probably, because it may theoretically be that all that you get, you may not get a brilliant view of an appendix for whatever reason. And starting with the most important of all, I would say the echogenic fat is the most important thing. So this is a sign of inflammation. A radiologist told me if we don't have inflammation, it's not appendicitis. The child needs to be tender, so that's a sign of inflammation. We see the brightness caused by the migration of all the inflammatory fat cells. It's a little bit like when you look at cellulitis. If you're scanning for skin, you look at cellulitis. The appearances that you get of cobblestoning, if anyone's familiar with those terms, is the sort of interlobular septa of with inflammatory fat globules glowing very, very bright with increased blood flow, and that's what leads to the pattern, and it's the same thing that happens with the fat in the right lower quadrant. On CT, it's called fat stranding, and sometimes radiologists will call this fat wrapping, where it wraps around in a structure. You can get the omentum. The omentum's kind of rich in fat, and it's the policeman of the abdomen, isn't it? As a surgeon might talk to you about it. It migrates to the area to try to deal with any infection or kind of burden of illness in terms of that. So here's some example of some brilliant kind of brightness from the omentum and some wrapping. Again, we've got a pretty much a full house of different things here. We can't really see an appendix. I think that's 2 centimeters, so that's not your appendix, but we've got probably a loop of bowel. We've got lots of brightness. We've got lots of other signs we're going to talk about later, which is a kind of almost a static ileatic loop here that's not really doing too much, and little pockets of free fluid in between. And then we've talked about this one before, with this just all being much, much brighter than expected. So next would be color Doppler enhancement. So putting your color flow on and getting an appearance a bit like this. You don't normally get any enhancement from color. All right. Anyone who's done any cannulas and IV access will know that to achieve a Doppler shift correctly at the right angle of intonation, you need to be fairly kind of spot on to your vessel. You don't want to be coming at it from perpendicular. You need to be coming parallel, ideally, to get a Doppler shift. And the point I'm making is that in order to make that Doppler look well on the screen, is you have to get kind of your angle fairly correct. So for low flow states, any tiny little branch vessels or anything, you're not going to generate a Doppler shift, and you're not going to generate color flow enhancement unless it's significantly inflamed, which is what these images here show. This is a really nice example of it. That's one I took. Any questions so far? Okay. Other secondary signs we see would be in terms of static loops of bowel, so localized ileus. This is a case I did really a long time ago, about like 3 years ago, and I sort of had probably just started scanning for kind of appendixes then, and I wasn't too sure what I was seeing. I just didn't think this could be appendix. It looked too thick in walls. Overall, it's very, very big. It's maybe getting on for 2 centimeters. So I didn't think that's what it was. So I did some kind of face-to-face supervision with some radiologists, both of which felt that it was probably a loop of kind of terminal ileum or a loop of bowel adjacent. But that being said, all of this is extremely abnormal, all right? Very echogenic, pardon me, in a child who had a very tender abdomen, which means that this is going to be something that needs surgical attention. Here's another example of some ineffectual peristalsis, very, very dilated loops of bowel, again in a different patient that I took. And again, if you see this is quite a worry. This is obstruction, effectively. Okay, free fluid. So free fluid you'd think means everything, but actually I don't think it does. I think kind of radiologists would tend to agree. If it's localized to the appendix like this, I think fair enough. We can see a big appendix, we've got free fluid, fair enough. And I'll be honest, both of these cases, this is my case as well, and this was appendicitis. But I've also had some examples where there's lots of free fluid hanging around. And I had a case just at the back end of last week, a few days ago, and it was this huge area of kind of localized free fluid, but the child just wasn't very tender, had had a bit of vomiting, and kind of a few features did not feel like appendicitis. So I called that as actually not appendicitis and said, we'll do your bloods, we'll ask the surgeons to review you, but I didn't feel worried enough that he should definitely go to theatre or come in, because after having had a good look around, I couldn't really find anything other than just little bits, and actually a large amount of free fluid, but we might not always get our answer why that is. And to be honest, more often than not, it doesn't always add up to anything. I've had girls in the department before with kind of complaints about gynecological things who've had huge amounts of free fluid. And then I've had a radiology scan done that same morning, and they just said free fluid, nothing else identifiable. And I remember this one girl, we just 3 hours later, she was so much better, completely better. We just sent her home, normal bloods, normal fairly normal radiology scan that agreed with the POCUS. So I don't think free fluid means everything, to be honest, but I would say a large amount of it, definitely, take it into account, but it's not the be all and end all. Okay, so I think this is one of Nigel's scans that he sent me, and this is just a brilliant example of appendicitis. Okay, so if you see this shouldn't be there. This is a massively dilated, distended appendix with thickened walls. Everything's fairly echogenic around it. And this is a big kind of turbid structure there, possibly an appendicolith because of what you see with some shadowing. Yeah, in fact, I would say it is. Yeah, definitely. So that's appendicitis, okay? Just show that to a surgeon. They'll come. Same thing, that's put the probe on, that's appendicitis. That none of that should be there. You've got a lot of echogenic material around it. Again, echogenic fat. Hard to make out exactly what we're seeing in this plane, but I would probably say we've either got, let's have another look, probably wall of appendix there, possibly compressed by an adjacent loop with free fluid or localized free fluid. Let's have a look at this one. Just all grossly abnormal. I can't explain enough to you how unusual all of this is. The image where I was showing you the small bowel and the large bowel, that was taken on me. I did that on myself last week. And you can see how it's very nondescript. The bowel loops are just peristalsis away. There's no bright, interspersed kind of almost septations within. There's no bright mesentery. It's just normally it looks like, you're scanning loops of bowel just going about the business. Whereas this, all very abnormal, all very abnormal. I wouldn't let this child go home. Same appendicitis, great example. Big, thickened, huge loop, thickened walls, extremely bright around it. And again, I think this one was one of mine. No problem, Milan. Again, very, very bright echogenic material around it with kind of, a root of the appendix there. We can't quite, you can see we're trying to kind of open it up and to look at it in two planes, transverse and longitudinal. And ideally, you'd want to follow this all the way to the end, see it in transverse and then rotate it into long, and then you begin to see what resembles an appendix. But this is appendicitis. Even if you only get that view, that's really abnormal. Same thing here, blind ending loop, very echogenic around it, all quite unusual. Probably measures quite small, this one. I'd say it would be kind of borderline in terms of measurement, 0.6, but all very bright, all very unusual. And you've got a tender patient, you're pressing there, you've answered the question. This is another example I've got whereby everything's wrapped around, probably a central structure there. That's really great example of a hyperinflammatory fat wrapping, all really abnormal. And again, more pockets of free fluid, really unusual shapes. Some of that fluid might be interloop, and maybe that's interloop there, probably is. But this bit looks much more like free fluid. It's got these sharp edges, spiky kind of edges and corners that shouldn't be there for free fluid, just beneath the muscle. Again, appendicitis. I think this was done by Bethany. Well done, Bethany. So really, really echogenic. And this was just a case of putting the probe on where it was sore, which for this child was quite low down from McBurney's, even lower than we'd expect, but it's appendicitis. Yeah, dead easy. So you're going to be bored of appendicitis soon. So I'll move it on a little bit. What do we think about this kind of thing here? Anyone brave enough to kind of comment either on the chat or speak up?
It seems to be appendicolith.
Okay, good. Yeah, if you can, just focus on the image on the left first, if you're able, please. But you're absolutely right.
Yeah, I'm Zafar Alam. Yeah, sorry.
What do you think about this one? Yes, so we're saying that it's some areas of echogenicity. I would agree. Thickened walls. Yeah, I probably agree. So one thing we've got to talk about when we talk about an appendix is we've talked about the gut signature going all the way through and the walls. But what's really important is that we've got to be aware that an appendix really, of all the ones I've shown you, either normal or otherwise, really just looks like a circle end on. So it looks like a target, a little target sign. I don't like that sign, that term, because everyone, it started to come into the literature a tiny bit, but I associate that with the intussusception. So I wouldn't say target sign or anything, but it looks like a kind of a circle with a dot. And whether it's normal or abnormal, what it doesn't have an appendix is this very interesting floral sort of outline, floral kind of projections of mucosa. And this is a really interesting case. So it's CRP of 5, but I scanned the child. I was like, this kid definitely has appendicitis. This is clearly. So you're absolutely right. There are some unusual features. And in this view, we see an appendicitis, echogenic fat, color flow enhancement, appendicolith, just unusual, very tender, unusual. However, if we look at this loop above, this is the bit I mentioned to you about an appendix being pre or post ileal. So this is definitely terminal ileum. I know it looks blind-ended on this picture, but if you watch really, really, really closely, just at the end of the clip, you can see this starts to probably merge. I don't know if it shows it as well in that one. Starts to merge with probably another loop and doesn't look as blind-ending. And in fact, this was appendix, and this was this same loop above. Does that make sense to everybody? So I think this loop and this loop are the same thing and will be terminal ileum. Just because you don't normally get these finger-like projections of the mucosa, you just get a very straight line, like a tube, and you just get the same in transverse section. So it's just a little bit of a pitfall to be aware of, all right? But you will crack it once you do enough of these. So what if you don't visualize the appendix? Well, I would say don't worry. I would say put it into clinical context of what you're thinking about and look for your secondary signs. If your right low quadrant appearances aren't as you expect them to be and they're abnormal, well, then something's definitely going on. But there could be some other pathologies. So if you see something massive, how big could it be if it's the appendix? We talked about my case where it was that huge loop. So again, studies have looked at this, and you can go up to kind of, maybe as high as even 1.5, based on this kind of broader range. I've seen kind of 1.2, 1.3. I don't know if I've ever seen beyond that, centimeters, that is, from outer wall to outer wall. And typically for a normal, we're going to be below 6 millimeters, so 0.6 of a centimeter. We're going to be 0.5 or 0.4, allowing for a little bit of kind of error and variation in it. And I think that's important because, again, if you had something that's 0.63, 0.64, non-tender and fine, lots of studies have shown that that in itself can be normal. So I would say you're looking for tenderness, you're looking for your pre-test thoughts about probability in this particular child, and then you're scanning. If it's big and they're tender with secondary signs, it's appendicitis. If they're not very tender and it's borderline 0.6-ish, I would say don't get too excited. However, it could be an early appendicitis, couldn't it? So it might be that you scan them 6 to 12 hours later and things are a lot different. Does that make sense with everybody? Hopefully. So how important is seeing a fecalith or an appendicolith? So lots of studies have talked a lot about this, either on ultrasound, CT. I would say the conclusion seems to be, from having read all of these, is that it's generally associated with more severe disease, so complications, but it also doesn't make a lot of difference in every single case. So in other words, you can have simple appendicitis with features of fecalith. However, if we don't operate on those who do have a fecalith or an appendicolith, you can have a much greater chance of perforation. Okay, so it's not always going to be there in appendicitis when you scan. It might be there in some of them, and I think from ours, I can't remember how often we've seen them, but it'd be a small percentage. The other guys could jump in. Maybe definitely less than 10%. No, maybe about 10%, I would say, of appendicitis, that is, not appendixes. What about lots of lymph nodes? So this would be a good example of what I would think is mesenteric adenitis that I scanned a little while ago. Turned out to be nothing more. Lots and lots of lymph nodes here. So we can see these bean-shaped sort of little structures that you will typically have this oval or bean appearance rather than be rounded. Rounded's a bit of a worry. They should normally have a sort of an internal echogenic hilum. So if you drop your gain on your machine and have a good look, a few of them give you a good example there of an echogenic hilum, which is the sort of nourishing kind of anatomical part of the lymph node that you see, the kind of normal hilum. This was a study just done recently that looked at how kind of some of the appearances of lymph nodes, and it had an interesting conclusion, which, although I know the kind of the author's quite respected in POCUS actually, but I did find the conclusion was interesting because they were classifying anybody with 3 or more lymph nodes as mesenteric adenitis, which I must admit I probably find a little bit on the low side, given that we commonly find 3 to 5 in a lot of people, maybe a bit more. I think when we're seeing 20 nodes, 25 nodes, that would be really consistent with mesenteric adenitis, and you can make a rule-in diagnosis, I think. Bear in mind you've spent a lot of time scanning, you haven't found an appendix, you haven't found secondary signs. I've also come to know, I think, through doing these scans, that they don't seem quite as tender as what I think for an appendicitis. You know, your colleague might examine and say they've got right low quadrant tenderness. I think when you get the probe on, I just get a feel that they're a level below appendicitis, and obviously that I know that makes sense. Obviously everyone would say that that's clearly the case, but I think that's crystallized in my mind of the ones who've just got a bit of discomfort when you see, you know, lymph nodes in this area, a bit sore in this area, whereas with an appendicitis, it's normally be you're scanning around, you see what you think is the appendix, you move away, and you go back to the same spot every single time, and the child has the same reaction every single time, if that makes sense. So yeah, so we were hoping to do some prospective work going forward in normal patients, looking at normal healthy volunteers, you know, so injury patients, and maybe scanning 200 kids and seeing how many lymph nodes are in their abdomen. So if anyone wants to link in for a study with me, that's possibly one of the next things we'll look at. Nice, quick, easy one. What about if you see massive lymph nodes like this? Well, some of the features of these lymph nodes are still normal. We've got this echogenic hilum and echogenic material. If we drop the gain of this machine, we'll see that it still maintains that. It's still fairly bean-shaped sometimes. This looks a bit rounded, so I'd want to have another look in a different plane. But yeah, generally bean-shaped probably overall. This was another child who was transferred to the tertiary centre after we did this scan just because of their age. There were only 3, but they did turn out to be nothing more and got discharged 2 days later after a radiology scan, confirmed the exact same findings and felt that it was mesenteric adenitis. So I don't think lymph nodes mean much, to be honest. It would be my view, and I think all the radiologists I've spoken to probably agree. Normally means mesenteric adenitis if there's lots. You would think an appendicitis would lead to lots of lymphadenopathy, just the way, you know, you think of tonsillitis, bacterial, giving you good going lymphadenopathy, that kind of thing. I don't think it seems to do that, to be honest. But I'll keep an open mind. Okay, so when should you be more worried? Well, I think clearly poorly patients warrant more attention. So this is ultrasound and it's amazing, but we've still got to treat the patient in front of us. So anyone who looks particularly pale, particularly sick, or, you know, isn't behaving as you'd want. If there's lots of free fluid hanging around, that's probably quite serious if there's so much. And then if you've got features of obstruction, this is an excellent example of obstruction. This child had an appendicitis, which we found as a result of causing his obstruction, probably. And what happens if you see something really unusual? A couple of times I've put the probe on and found something quite strange, hopefully not as severe as this grade of hydronephrosis, which is certainly severe, probably grade 4, at least, depending on what the urate is doing. But you might see a bit of hydronephrosis, you might find something unusual kind of hemorrhagic ovarian cysts that aren't related. Obviously they could be related to pain, but it might be something ovarian that's unrelated or something completely separate. I think just do all of this, explain what you've seen and get a formal scan. We can never think of POCUS as being a comprehensive assessment. That's not physically why we're employed by the trust. We're not there to do that for the patient. We don't have particularly all of the expertise to do it or the correct equipment machine. So I never think that that's what I need to do. But equally, if we find something really unusual, like a metastatic tumor in the liver, which unfortunately I had recently, we can take the correct action, I think. So we're always going to approach that in a governance sound manner and probably do the right thing. So pitfalls that you could have come across could be the false positives, which is thinking something else is the appendix, of which we've talked about a few, terminal ileum being the main one. You might see the appendix but not have appendicitis, so it might be borderline for size and appearance, but they're not that particularly tender, and you just think, okay, well, I could label it as appendicitis, but equally you probably just need a bit more time, repeat the scan by radiology in the morning, that kind of thing, observe the child. I don't think you'll come across too many that worry you so much that your images aren't fitting with what you see. I just think it really does match up so well. It's one of my favorite things to scan for that reason. So we talked a bit about this. I probably could have put this slide a bit earlier, but yeah, this is what I was telling you about, this outline, this floral outline of a terminal ileum versus the circle and the dot of an appendix with the different walls in position. Does that make sense to everybody? So this was a case I had in the right iliac fossa, which I scanned. I knew it was unusual, but I knew the appearances didn't look exactly right. This turned out to be a Meckel's diverticulum with lots of free fluid. So features of Meckel's can be very similar. We've got a fixed, non-compressible structure, which in the shape of a cul-de-sac, in the same position with a similar size. So you can imagine how a lot of the features are very similar, but I don't know if you can see this now with this kind of mucosal projections. I think knowing now what I know, I would be happy to say that that's not appendicitis, actually. I didn't quite get a transverse view. There was a perforation. The child was quite sick, so did need to go to theatre. False negatives would be not seeing the appendix because it's retrocecal. I don't know if I've come across any of these myself yet on scanning. I've got one case coming up where it involved that, but I've never actually, had a scenario where we've missed one who's been retrocecal, who's gone to theatre and we couldn't see it. I guess bigger patients will be a problem, and if everything's perforated, it can be quite tricky. So I would just say practice. So then if you start seeing unusual appearances like this, which is just when the bowel loop folds in on itself and looks like, is it free fluid? Is it interloop fluid? Just practice and do it non-contributory. Don't scan and decision make on them. Just scan to practice as much as you can, because the patients don't mind it at all, and you'll get really good over time. And I think this is one scanning modality where I just caution people a little bit about going away and doing it after today's talk or after any brief bits of teaching. I think you've just got to probably have a little bit of good face-to-face supervision to get decent at it before you do it, as fun as it is. If anyone wants to travel up to our department, I'm more than happy to spend half a day teaching people. So I'll whiz through a few cases and then we'll get on to some evidence at the end to finish. So this was a 5-year-old girl who'd had some vomiting and some fever for a couple of days, but also had loose stools. She was in a very pink bedroom like this, and this was her loop. We talked about this. So although I didn't think this was appendix, all her appearances were quite unusual. There's a suggestion possibly of some strands of free fluid and maybe some distended loops down here. I knew this was all very tender and very unusual. She had unusual bloods, and she was an appendicitis. So even though that loop wasn't appendicitis, we knew she was unusual. And then she went for histology, which confirmed that. This was a girl who had some migratory pain over 14 hours. She looked flush, she looked convincing. Bloods were, again, fairly kind of, enough to make me take note, I would say. She had all this free fluid. Couldn't work out exactly what was there, didn't quite see the appendix, but I could see this big wrapped thing. Now that you can see this, it looks wrapped because it all looks very circular. So I thought, well, an appendix is bound to be in there somewhere. And I was happy to say this is going to be appendicitis. So she got a radiology scan And they said the appendix was not identified, making it unlikely, which I thought was odd. It only happened about 4 or 5 hours after I'd done my scan. But she went for MRI, and she did have a posteromedial appendix, or retrocecal appendix here, which they thought was appendicitis. And she went to theatre and had a retrocecal appendicitis, which is really unusual because, I mean, you can see clear as day here that it's the focus of a lot of inflammation. And I guess probably the point is that we can't definitively call that the appendix. But to be honest, even then, you've got enough of a feel that you're going to call that. Interestingly, when she went to theatre, the histology section said it was only up to 5 millimeters, which is quite unusual, not 6. So it's quite an odd one because that wouldn't fit with our cutoff. And then it's just a very quick case I want to talk you through that was a bit of a mimic, where a 12-year-old boy came in who looked possibly like an appendicitis based on his appearances. He was walking with a strange gait, whoops. And we've already talked about his images, quite bright, and some colour flow enhancement, quite bright. Couldn't quite tell what I was seeing here. Couldn't quite see his appendix. So his bloods were doing nothing. So the surgical team sent him home. Said it could be viral. We came back, and this is what I wrote in the notes, and his pain was much worse. And this is what we saw, some free fluid. And then what I thought was a circular structure, so I thought it was quite strange. Little whiff of suggestion of maybe an appendix there. And then that progressed to this, what I thought was a clear appendix. And all this is very unusual. What I've got to tell you is all this is extremely unusual, very echogenic, very unusual. And then I measured it, so it looked enough for 0.61 of appendix, but all very tender, all very unusual. But there was just something about them that wasn't behaving like appendicitis. Just something that wasn't quite, either through progression of vomiting or he still had a bit of an appetite. So bloods 3 days later, still the same. Surgeon's not impressed. Radiology scan, you can have a read. What I like about this was the radiologist was kind enough to come and review my images. So that was really nice. And she'd agreed that the features did look like appendicitis and possibly a perforation. And he was very tender. Bloods were still doing nothing. Surgeon's winning so far. Eventually goes to theatre because he's no better. Normal appendix, no evidence of perforation, but he actually had this really common diagnosis, not of a mental infarction, extremely rare. It could clearly catch you out. And I think what happened here is that the parents were really pleased overall that we'd advocated for this child, and he had pain, he was no better, he was in a lot of pain, and clearly he needed some surgical attention. And then someone's asking in the chat, is there a minimum age of the patient where we can suspect appendicitis? Remotely, I remember that 2 is unlikely. So I've definitely had a couple of age 2-year-olds with appendicitis. One of them was that horrible perforation I talked to you about. She looked quite well, but her bloods were through the roof and her POCUS was crazy. I don't know if I've ever seen it in a 1-year-old. I guess you just have to look at the literature. I would say the key here is you could scan anyone, couldn't you, for reassurance? You could put a probe on, make sure you're not missing something unusual, interception. So I think certainly about 12 months and up, I bet appendicitis is still a thought that you have to consider. Not that I've particularly seen it. Hope that helps, Billy. So just final bit before handover. So we've done some data looking at patients. We're aiming for 150. We've got 149 at the moment. And sorry, this is in the way. I can't read that because I've got something popping up on my screen. Sorry. So you can see that in mean age of around 9, more females than males, and about kind of 12-13% were finding appendicitis. So I think that's about right, because that really does fit with, just by fluke, all of the prevalences that you read, in terms of we're not scanning too many, just any one willy-nilly, and we're not always getting appendicitis. That would be a worry if everyone we were scanning was appendicitis. Probably means we're not doing enough. And then just some data here. I just want you to focus on the difference. So the statistics were done by a kind of a statistician, which is great because it's the first time I've kind of done it that way when I've written anything up, and it seems so much more robust because I couldn't do this and I wouldn't understand all of it. But in terms of what's statistically significant in terms of the markers, the only things that came out just about CRP. So those who did have appendicitis did have a slightly higher CRP compared to a lower one, although not a massively high average CRP. But look how statistically significant the results of POCUS are. We're identifying it every time in terms of true positives, so sensitivity, and in terms of true negatives, we've only overcalled it on a couple of occasions when it turned out to be. Now there are a few caveats to that as well, but this is how our sensitivity and specificity are coming out, and positive and negative predictive values, which obviously we're really happy with. So we're due to submit that quite soon. So yeah, that was better than expected, I guess. But I think for the day-to-day user, so me and a couple of colleagues who do it in my department, it is a brilliant test. It is the best. It's my favorite question to answer using ultrasound because of that reason, because you know you're not likely to miss someone falsely negative, because you know they're tender, you know they've got some secondary signs. Even if you don't see an appendix, you can keep them in, and you check the bloods, do everything, integrate your POCUS really well the way you're meant to. But equally in the child who's absolutely fine and non-tender, I might not even be doing the bloods. I might just be scanning them, and I know I'm fairly happy because I've looked around for 5 minutes. They're not that tender, they're distractible, and they've got no secondary signs, they've got no appendix. And it is just, I think this will be a real game changer for pediatric emergency medicine, not necessarily our study, but the idea of using POCUS. So hopefully you guys will get on board after today and learn how to do it. And just the final slide for me was just that in the same time, we've done 149, we've only ordered 98 from our department, and that's within the same time period. So as was one of my consultant colleagues talked to me about, we're shifting the bulk of the work to us. So I know for the policy makers and people who are here from the network in the audience, this is illuminating because it's telling us that we're doing this more frequently, and that's a great thing because of the shortage of pediatrically trained radiologists and the fact that we don't want to overburden radiologists. We should be doing this ourselves, and we can make the decisions without having to kind of burden the service. So again, I thought that was quite interesting. And then last thing is that we know that not everyone with appendicitis goes to theatre, all right? This is just a thing. So it's a bit annoying because we've marked ourselves down a little bit for a few bits that were falsely positive. So specificity goes down a little bit, but not everyone gets operated on, and there were 2 or 3 in our study that weren't operated on. And I've known this throughout being a peds trainee, that definitive ones who, radiology confirmed, ultrasound, bloods, everything, they don't always need to go to theatre. And in fact, lots of trials have looked at the benefit of this. Right, enough of me talking. So for the last 5 minutes, I'm going to hand over to Bethany, who's our current POCUS trainee. She's helped us with the study, and she's going to talk you through some of the evidence that she's been looking at as part of her systematic review recently. Take it away, Bethany.
Is that working if I move the slides as well? Can everyone else see that moving?
Yeah. I can't. Oh, no, I think we're saying yes to hearing you, but I don't think you can move the slides. Can you guys? I can't see them moving anyway. Can you guys see them? No. Right, no, I'll move them.
Cool.
Right, cool. They're not moving. I'll move them. Right, you ready? So
I, as part of my PG cert, I've done a systematic review, just looking at the use of POCUS for pediatric appendicitis. I found 8 studies, and the top 3 were done in America. The one by Kim was in Korea, and then further down, America, Canada, America, and Italy. So majority sort of in the US, but there are some from the rest of the world as well. Only one of them was retrospective. So by Davis was a retrospective study. The rest of them were prospective. The one by Fox did adults and peds, but did provide separate data for peds as well. But the rest of them just looked at kids. The sample sizes varied, some of them quite a lot larger, some of them were some smaller studies, and typically the prevalence of the appendicitis was around about 30%, with some a little bit higher and some a little bit lower. The exclusions sort of varied for a lot of them, but typically it was if the main one that was common was if the patient was unwell, requiring resus, and then obviously it wasn't done at the time. Or in all of the studies, the ultrasound was just done by sort of emergency medicine physicians or sort of residents, how they tend to refer to it in America. But the level of training for all of them varies between the studies. Most of them did require some form of sort of teaching, either a lecture, but only 2 of them, so the one by Civet and Doniger and Cornblith, required some supervised scanning beforehand. Others just mentioned that they attended a lecture and then sort of they were happy to scan after that. In terms of a positive scan, the common theme was the same things as what Dave's been saying: a non-compressible tubular structure measuring more than 6 millimeters. In terms of negative scans, some of them did just want to look at, it was only negative if you could completely visualize the whole appendix, and say that all of those other features weren't present, which did alter some of the results for some of the studies. In terms of the reference standards, the key one was the pathology, and then follow-up if they hadn't went to theatre. Sensitivities did vary, with the lowest being 53, the highest being 100. There was less variation in terms of the specificity, so that was a lot more sort of 80% and above generally, suggesting more that it was good to rule in, but there was variable evidence for sort of ruling it out. But again, it was just a couple of the studies that were a little bit lower. Most of them were quite a lot higher. Yeah, cool. Next slide, please. Is that moved?
Yeah, can you not see it?
Sorry, it hadn't moved on that, but it has now. So I was just going to go through a few of the studies, so not all of them, just mainly ones that had something a little bit different about them or had some secondary outcomes that they also measured. So this study, as sort of they looked at the CT rate as well, and they found quite a big reduction in how many CTs that they were doing during the study. From the start, it was 44%. To the end, it was 27. So they did see that whilst they were using POCUS to look for appendicitis, they found the number of CTs they were doing in the department had reduced quite a lot. Another one was that they found that the length of stay in the department, again, reduced quite significantly. So if the patient needed to wait for a CT scan, the average length of stay was 407 minutes. Compared to if they had POCUS, it could be as low as 154. And even from having radiology ultrasound as well, it reduced the length of stay in the department, which obviously helps a lot with flow through the department and just getting patients sort of moving along and sort of help with their treatment as well. They also looked at sort of the people who were performing the scan and grouped them into novice or experienced, and they did find that the sensitivities varied by about 28% between the novice and experienced scanners. But the specificity didn't vary as much. So really just showing that experience does help quite a bit when you're doing the appendicitis scans. But it is more important really for ruling out appendicitis if the smaller difference in specificity is more suggestive of if it is positive, you will know it and you will see it. Whereas if it's more difficult to say, yes, it's negative and be confident enough to rule that out. They found that they had no missed cases and no negative surgeries as well. And they also looked at the sensitivity and specificity of radiology ultrasound and of CT as well. So they did find that radiology ultrasound was very similar to POCUS, but they found that CT had a bit of a higher sensitivity. But even the radiology ultrasound sensitivity is quite significantly different from a lot of the other literature in this paper, but their sort of sensitivity of POCUS is quite a bit different to some of the other papers as well. So Donoghue and Cornblyth, they integrated POCUS into a staged algorithm. So if they were eligible for the study, they had a ultrasound, they had POCUS, they then all had a radiology performed ultrasound afterwards. And then if this was equivocal, they then had a CT scan. They again found a big reduction in CT scans by 55%. And in the paper, it does say that that was only sort of because they were relying on the radiology performed ultrasound. They would have had an even bigger reduction if they'd just if they'd used POCUS alone. They also compared POCUS to radiology ultrasound and found that in terms of sensitivity, it was better, specificity not as good, but still sort of both were quite high. And on sort of the learning curve aspect of it, again, similar to other studies, they looked at the first and second half of the enrolled patients and found that sensitivity and specificity increased and the number of false positives decreased as well. Just showing that the more scans that you do, the better that you do get at ruling it in and out. So Davis was the only retrospective one. In the hospital that it was done in, their test of choice was an MRI. So they didn't look at CT at all, but they did look at POCUS and compared it to MRI as well. And found again very similar sensitivities and specificities, and they concluded that POCUS for their study it was as accurate as MRI. And the main difference with their study as well was that they said that it was equivocal if it was between 6 and 7 millimeters, which did alter some of the stats for them as well compared to others, just with the measurements being a little bit different. And this one, so Balbo was the most recent of the studies that I found, only sort of done last year. In their study, all patients had a radiology performed ultrasound as well as POCUS, and they found that concordance between the two was good/excellent. Similar to the other ones as well, they found that the duration in terms of the learning curve, the time taken to do POCUS decreased as the number of scans increased. So as people becoming more confident, it wasn't taken as long. So initially it was taking people about 10 minutes. Towards the end of the study, it was only the mean was about 5. Just again showing that experience improves not only your ability to do it and rule in or rule out, but how quick you're able to perform it as well. They did find as well that the time taken for POCUS was lower in patients that had appendicitis, again showing that if it's there, you are going to be able to see it, and it shouldn't take too long to find it. And they asked the doctors performing it to do like a self-assessment score, so saying how confident they felt in their results, and found that again this increased with the number of scans done. So they were taking less time, and they were much more confident as the number of scans increased. So this one was the study that was done in Korea, and was a bit a lot different to the other studies really. They looked at sort of tele-ultrasonography in diagnosing appendicitis. So they had the EM residents performed an initial scan, and the scan was then transmitted to sort of a more expert ultrasound skilled physician who was watching on a smartphone from another room. They didn't initially say anything. The resident did the scan, made the diagnosis, and then they re-performed the scan with guidance from the the skilled physician who was watching on the phone. If the physician had already made the diagnosis just by watching the scan on the phone, they then didn't get them to redo the scan, and just did it from there. The person on the phone then went in and verified the diagnosis. So the sensitivities and specificities are split up at the bottom in the graph, just showing that the resident performed was slightly lower than the tele-ultrasonography, but the teleultrasonography and on-site expert were very similar. So I've lost my words. The tele and on-site expert, it didn't really make that much a difference in terms of whether they just watched it on the phone or whether they did it in person. So we're basically just trying to see if, when there's not someone available on site, could this be something that they could integrate into the department, having someone from home just being able to watch it and then guide people on site to do it. So theirs was quite an interesting study as well, if anybody wanted to read that one. So basically, from the report, it's shown to have a high specificity but variable sensitivity. So it can be used to diagnose, but it may not be the best alone to exclude appendicitis. It might be best to integrate other things, so making sure that you use your clinical findings and other decision scores as well. It has a similar accuracy to radiology performed ultrasound. It reduces the length of stay in CTs, and as you do more, you feel more confident and you become better. Thanks.
Thank you, Bethany. That was great. Thanks so much. So yeah, that's a really nice systematic review she's written that we're going to submit. So look out for that. And yeah, all the more reason for us to push on with our data, and hopefully we can get those performance criteria nice and high. That is all we've got for today, guys. Thanks so much for sticking around for all of it, because I know it took like an hour and 10. Hopefully it was interesting. I know there's lots of detail in parts, but it'll be recorded if you want to go back to it. So it'll be on the YouTube channel. Just type in PEM POCUS UK. And yeah, thanks for continuing to come along to PEM POCUS UK. It's really great that everyone's got enthusiasm for it. So we really appreciate it. We're going to have Nigel Chan next month, date to be confirmed, and he's going to do some cases. And Nigel's been scanning for sort of 18 months or so. So that will be, that'll be really nice for the more novice scanners and stuff. That'll be really nice to get his perspective on how he's been doing things over the first year or two. If there are any questions, I'm dead happy to answer them. Share the recording.